I'm presenting to you a 10-month-old, 25-pound intact female beagle mix that is named Sally, and she's here for a spay. So upon her physical exam, her temperature was 100.9 degrees Fahrenheit, her heart rate was 120 BPM, and her rest rate was 20 rests per minute. Her mucous membranes were pink, moist, and her CRT was less than 2 seconds, and she does not have any concerns today for anesthesia. Sally's anesthetic procedure, her pre-medications consist of acepromazine, atropine, and buprenorphine, and all of these will be given IM in her semimembranosus, semitendinosus muscles, and then we will be inducing her with IV propofol, and prior to her procedure, she will receive sub-Q Onsior. Then after her procedure, once a day for 3 days, she will receive Onsior by mouth. Sally will be receiving her Onsior sub-Q injection 30 minutes pre-operatively. Sally will also be receiving fluids during her procedure, so her PRI, or prescribed rate of infusion, is 114 mLs per hour, and her volume to be infused planning this 30-minute procedure for a spay would be 57 milliliters per 30 minutes. And her drip rate would be 1 drip per 2 seconds. Once our patient is approved by the veterinarian and calculations are checked, our pre-medications can be drawn up, and each syringe must be properly labeled with the patient's name, the date, the name of the drug, the concentration, and my initials because I drew them up, and then I will fill out the controlled substance log as well as the class drug logs, and then I am able to administer my pre-meds in the semimembranosus, semitendinosus muscles, and I will make sure I record what leg this was given in and what time. For Sally, I would set up a rebreathing system because she is over 7 kilograms or 15 pounds, and I would use a universal F2 because it allows the expired air to warm the inspired air. So I would start setting up the anesthesia machine by following the flow of oxygen. So I would start in the oxygen room, check the oxygen tank, make sure that it is above 500 psi, and that it is properly secured to the wall. I would also look at the pressure reducing valve or the regulator, which reduces the pressure from in the tank to 50 psi. And then the oxygen flows from here to the anesthesia machine into the oxygen flow meter. So the oxygen flow meter reduces the pressure to 15 psi, and it regulates or maintains the oxygen within the system. So from the oxygen flow meter is the oxygen flush valve, which can be used to give the patient 100% oxygen if necessary because it bypasses the vaporizer and the flow meter, and it also is used to dilute the anesthetic gases and fill the system when doing a leak test. You never want to use this if the pop-off valve is closed because it will build up pressure in the system and it could cause damage to your patient's lungs. So after your oxygen flow meter, your oxygen flows to the precision vaporizer. The vaporizer holds the liquid anesthetic gases, so the oxygen and the anesthetic gas will follow out the vaporizer from the fresh gas outlet to the unidirectional valves, where the F-tube will be attached to the inhalation valve, go to the patient, and then to the expiration or exhalation valve. And above the exhalation valve is your pop-off valve, which should always remain open, and it should only be closed if you're giving a manual breath to your patient, and then immediately open afterwards. Following the pop-off valve, the rebreather bag should be set up, which for this patient, Sally, is 11. I attach a 1-liter rebreather bag for Sally, and then the CO2 canister is next, which absorbs the excess CO2 out of the system, and it should always be checked before each use of the anesthesia machine. And then the scavenger system is a passive and gravity-fed system that the F-air canister should be weighed before each use, and make sure that the vents on the bottom do not get blocked or pressure will build up in the system. Once the flow of oxygen has been checked to ensure that the anesthesia machine is set up properly, there are certain aspects that must be checked and maintained before it can be used. So this includes checking the oxygen flow meter. So you want to turn on the oxygen, make sure that the ball in the oxygen flow meter is steady and it is not dropping or wavering in any way. And then you want to move to your vaporizer, check the amount in it. If it is below the line, you should fill it to the recommended amount at the line, and always make sure that the cap to the vaporizer is on tightly. And then your CO2 canister, you want to check the granules. Even though they do change color and they should be purple when they're expired, the color is not always apparent, so you want to take the granules out and you want to crush them. If they're easy to crush, then they are not expired, but if it's difficult, they are expired and they must be replaced. From there, you want to check your F-air canister. Before each use, you want to weigh it, and if it has gained 50 grams since its first use, then it must be replaced. If not, mark the date and how much it weighed at the time of use. Once these have been checked, a leak test can be performed. So start by closing your pop-off valve and then occlude the tube at the patient's end. You want to make sure that your flow meter is off, and then using the oxygen flush valve, fill the system, watching the manometer to 30 centimeters H2O, and your pressure should not drop more than 10 centimeters H2O in 30 seconds. If it does and a leak has occurred, you want to check the most common places like the CO2 canister, the rebreather bag, and the hoses and the connections. If there has not been a leak in the system, then you want to open your pop-off valve and then release the patient end of the tube. The scavenger system should also be checked after the leak test has passed, so your pop-off valve should remain open for this. You want to also start by including the patient end of the F-tube, and then turn your oxygen flow meter on to 4 liters per minute and leave it on to fill the rebreather bag. And then you want to monitor the manometer during this. The pressure should not build above 2 centimeters H2O in the system, and if the pressure builds more than this, then you know there is a blockage in your scavenger system. Again, make sure that the vents on the bottom of the F-air canister are not blocked, because this could be a reason. Once the anesthesia machine has been properly assembled, following the flow of oxygen, the flow meter, the vaporizer, the CO2 canister, and the scavenger system have been checked, and the leak test and scavenger system check has been completed and passed, the anesthesia machine is ready for use. Prior to the surgery, I will set up the following equipment. So the warm tables should be turned on, and any warming devices. So because this patient is 25 pounds, I'm going to turn on the heated tables in the prep room as well as the surgical suite, and I'm going to also set up a hot dog to keep this patient warm during the procedure. I'm also going to be using an ECG monitor that should be turned on, and all supplies gathered that's needed. So the cables, the ECG pads, alcohol, and a towel. And then when it's ready to be used on the patient, the lead should be placed with the white on the right front, black on the left front, green on the right rear, and red on the left rear. And then once we are ready for the ECG monitor, I will be able to identify a normal versus abnormal rhythm, and there may be interference in the reading caused by other machinery such as the pulse ox and a blood pressure monitor, which the pulse ox should also be set up at this time. It will be plugged in and turned on, and the transmission probes are ready to be applied to the patient on a non-pigmented tissue such as the tongue. I will also set up a capnography. This monitoring device should be set up with a side stream fitting so that it can be placed directly between the patient's ET tube and the breathing tube, and it will measure the end tidal CO2. The normal range is 0 mmHg during inspiration, but it can be up to 8 millimeters Hg in a normal sense because we are using a rebreathing system, and this is due to the recycled CO2 being in the rebreather bag. And then the normal expiration of CO2 levels may increase to 40 millimeters Hg, but up to 55 is also considered normal because of the respiratory depression that is caused by most anesthetics that are used, causing the body to retain the CO2. And an abnormal NCO2 may be decreased because of hyperventilation, it may be increased because of hypoventilation, and it could also be abnormal because of a blocked ET tube. Indirect blood monitoring equipment should also be set up, including a Doppler and oscillometric. So the normal blood pressure values include systolic 90 to 160 millimeters Hg, diastolic is 50 to 90 millimeters Hg, and MAP is 70 to 120 millimeters Hg. So the Doppler, you need a Doppler unit, a manometer, an ultrasonic gel to apply to the probe, and that will be placed on the medium palmar artery, and the appropriate size cuff should be chosen, which will be 40% of the circumference of the extremity that I decide to use. I'll need to shave the hair away from the area that the cuff will also be placed on, and then attach the manometer to the bulb and cuff. And when the patient is ready and under anesthesia, the amplifier will need to be turned on, but make sure that the volume's turned down if doing this before the patient's under anesthesia. So I'm going to adjust the probe until the signal is heard, and then place the probe over the artery until you can hear the arterial sounds of the blood flowing, and then inflate the cuff to approximately 200 psi, and then slowly release it until you can hear the whooshing sound again. So deflate the cuff fully and repeat this process 3 times, and then take the average of it, and it'll give you the systolic blood pressure measurement. The oscillometric is also a blood pressure monitoring system, but this one will measure the systolic, the diastolic, and the MAP. So the monitoring requires a small amount of work. You need the non-invasive blood pressure monitor, and then an appropriate size cuff that is also 40% of the circumference of the extremity, just like the Doppler, and this should be attached to the machine. And then when it's used on the patient, the cuff will be placed around the medium palmar artery like the Doppler, and all you have to do is press the button on the unit and it will inflate the cuff. And then there may be malfunctions if the patient is either moving, the incorrect cuff size has been used, or the cuff has been placed in the incorrect place. And again, this gives you the systolic, diastolic, and the MAP. I've also chosen a medium esophageal stethoscope for this patient. To use this, I'm going to first measure the tube against the patient in order to determine how far down the esophagus that it should go, and then I'm going to apply lube at the end of the tube and gently pass it to the back of the throat and down the esophagus, where I'll be able to listen to not only the heart but the lung sounds too, and able to get an accurate heart rate and the respirations. Sometimes this can be better than a normal stethoscope because it always allows you easy access to the vitals without being in the way of the surgeon during the surgery in any way. You are closer to the lungs to hear sounds you may not be able to hear otherwise, and it allows your vitals to be obtained in the same place. I'm also going to set up my fluid pump. So first I'm going to need to gather all of my appropriate materials, including my fluid infusion pump, the fluids that are decided by the veterinarian, a fluid administration set, a macro drip set, and 1-inch tape with an extension set. I'm going to set up the fluids so that they can easily be connected to the patient's catheter and begin receiving fluids. So I'm going to first do this by removing the plastic from this fluid bag, and I'm going to label the bag with the patient, the date, the time, and the amount of mLs in the bag before starting. And then I'm going to attach my fluid administration set sterilely. I'm going to connect my extension set, and then I'm going to compress here and allow this to fill halfway. Once the fluid line is set up, I can open my clamp here and allow fluid to run through the line, getting rid of the excess air. And then I can take my line and I can turn on my fluid pump. I can set my PRI to 114 milliliters per hour, and my volume to be administered at 57 mLs for 30 minutes. And then whenever ready, I can connect my fluid line to my patient's IV catheter, turn the fluid pump on, start.